Ladies and gentlemen, dear friends and colleagues, it's a great pleasure for me being here today to talk to you about the WHO and what we do in the field of health information and health informatics. I've been at WHO for more than 25 years now. And being a skeptic myself, I question every word in the title. World, do we represent it? Health, do we really conceive it right? And organization, I question the most. Are we really organized? So maybe they don't therefore like me much and call me the young Turk. I'm not anymore young, as you can see, but I still keep the spirit. So I will share with you what the work and the insights. And basically, I will ask you, how can you help? Because it is your organization. It's not also an independent organization. It is basically a public organization that serves the people. We are the stewards of public policy. So, this is my liberation slide. Those are my views, not that of my organization necessarily. And I believe in scientific methods, and I warn you, I believe in ontology. So, that is my bias. And let me give you the gist of my talk. The first commandment of my Decalogue is avoid an E-Tower of Babel. So that is the summary. If you remember nothing from this talk, just remember the Tower of Babel and don't do an E-Tower of Babel. I have 9 other commandments in other talks. So, well, first, when we talk about the World Health Organization, people conceive it in the context of disease and health over the history. Is anybody can turn on this screen, if at all possible, so that I don't turn back my audience, but if not possible, I will do so with apologies. And as you can see, the world has been plagued with multiple pandemics, epidemics all throughout the world, and we have given a global response to the epidemics. And I've summarized in this slide the pandemics until the 20th century, and in the 20th century we had very many of them, as you know, from HIV, tuberculosis, malaria, and recently Ebola. And I was sitting in our governing bodies meetings on Ebola. You simply think, is WHO the World Ebola Organization? Or are we the World Health Organization? That is, for example, that makes me this skeptical approach. Of course we should deal with Ebola, there is no doubt about this, but I don't think that we should have tunnel vision. So, let me make my first thanks to the organizers. I mean, having the FAR Institute featuring in Digital Health Assembly gives me an immense pleasure being here and giving this keynote. Because as you may know, or may not know, because FAR is not as famous as Jon Snow, he was the father of the ICD. And here I am, the responsible officer of WHO for ICD, 150 years after FAR's proposal, presenting to you WHO's work, and mainly I will focus on ICD. So it is an interesting confluence of memetics, scientific memetics, I would say. And I think what he has done in the analog space, we should repeat in the digital space. Of course, FAR himself was not the first one, and 350 years ago, in London, you had the London Bills of Mortality with John Gaunt and so forth. So he took it from his predecessors and lent to us. And we took it from him. Thank you for your mother-in-law. We took it from him, and we have updated ICD over the century every 10 years. And basically, what FAR did was very simple. I call them the shepherding requirements. Count how many people are born and count how many dead. That's it. Every good shepherd does it. And if you can't do it in my country, I come from Turkey, you cannot be a shepherd, but you can be a politician. So the second corollary to this is that don't cry wolf. And as you may know, very many people attract attention by crying wolf. Now I'll show you when we use FAR's instrument over these 100 years, we have built more than 400 million person years of mortality data. So we know what people die of, at what age, and so forth. And this is the map of the world showing the mortality statistics where we have data. Good, isn't it? But look at this part. Okay? The white place, we don't have data. Does it look like this picture? This is the picture of the Earth at night, showing the scintillation of lights. So wherever there is light, there is data. Wherever there is no light, there is no data. So that something is wrong with this picture. And if you look at it, we estimate the mortality. If you look at it into the countries that have FAR-like vital registration, this is the burden of mortality in terms of years of life lost. You can see this black part is estimated to have 4 times more mortality than the other part. And this is Africa, and this is the southern hemisphere in many other places. So this is an information paradox, I call it, because we don't have data where we need it most. These are the countries where we have HIV, tuberculosis, malaria, Ebola, and we don't have appropriate systems whether people are dying from these diseases. And even though we are pouring billions of dollars to fight these diseases, we don't have a monitoring system. So that I wanted to share with you because it is some of the deepest ethical and technical concerns that I have. So I show you this slide. If you go to Turkey and if you enter into a carpet shop, you're very, very likely to buy one because they won't let you without getting out without one. And this is a very nice carpet. But would you buy this carpet? This is exactly like the mortality data in the world. 60% of this carpet is missing, and 60% of mortality data is missing. Would you buy this carpet? And however good a carpet merchant I am, can I sell you this carpet? But I can sell you mortality data. And this is the beautiful carpet. So what I'm saying is that how informatics savvy you are, you cannot impute the internal design of this carpet from the edges, borrowing strength from the neighbors, Bayesian theorems, and so forth. You cannot make it. And this is another slide from the United Nations Statistical Division, and it is from their report, October 2014, which is relatively recent. And we had, with all the nations, focused on the Millennium Development Goals, 15 of them. And as you can see, they also say that the available data is in green. The rest is under either adjusted, estimated, modeled, or some sort of survey data, global monitoring type of thing. And as you can see, all of it adds up to 60% or so, and they haven't made it up to 100% the scale. So, as a matter of fact, you know, not only for mortality, but for other education, poverty, and other health goals, 8 of them are there, we don't have enough data. So I'm the first one to welcome big data, but big data is worse than the Swiss cheese in terms of the holes at global level. So I counter-hired Dilbert's boss as my consultant. And as you can see, he says, consultants say that 3 quintillion bytes of data are created every day. It comes from everywhere. It knows it all. According to the book of Wikipedia, good reference, its name is Big Data. Big Data lives in the cloud. It knows all what we do. So he's a good consultant, refers to the Wikipedia and tells me what I didn't know. And, well, this is something I wrote. Using it is the hardest part. Of course, we have the data, and I think if we were to use it, we would make many remedies to the ill. So, one of the things that I learned from Star Trek is the Finagle's law of information, which applies to big data and WHO's data. You may know that. The information that you have is not what you want. What you want is not what you need. And what you need is not what you can have. And in the instance of big data, this law applies too. So there is a big gap between what you have, what you need, and what you want. By the way, I see that some of you are taking pictures. I'm putting all my slides into the slide share. So from Twitter and Facebook, I'm a believer in public sharing. So I cannot share ICD for commercial purposes, but I can share my slides because I make them. So, and I borrow other people's slides. This is a slide that was inspired by Ian Buchan, my friend, and he had put this analytical process in perspective for me to teach my directors and senior staff, is that it's not only about data. What adds value to data is the analytical process, statistics, aggregation, ontologies, and then we can have the output as knowledge, mechanisms, interventions, and policies. Therefore, the health information needs health informatics. And conversely, health informatics needs health information. They will condition each other, and this is not a unilateral relationship. It's probably a bilateral and a spiral. So we should really think about this process hard and long to make it more meaningful. Otherwise, you cannot have garbage in, gold out. In computer science, most of you are IT savvy, garbage in, garbage out. In order to extract the gold there, you really have to build the big intelligence. Otherwise, I will call you New Age alchemists trying to convert garbage into gold. So, why is this so important? Well, when we are working with ICD, every time people comes and say, well, this is reinventing the wheel. Well, maybe we should be reinventing the wheels of the future. Maybe we should invent vehicles without wheels, like hovercrafts or other type of things, So it is important that we also have a shared meaning, because wheel serves multiple meanings to many people. And I was trained as a psychiatrist at the beginning of my career, then I went into health services research and reported myself as health statistician, health informatician, maybe health ontologist, I would say. There is a big gap between what you say. Even now, I wish to express certain things. I think that I have expressed them well. But then, I really don't know how well you want to hear it. You actually hear it. You wish to understand it, and you understand it, and you accept it, agree with it, and align your thoughts with it. There is a huge gap. So, I think apart from sharing meaning in terms of semantic interoperability, we need some sort of a human interoperability as well, but it's difficult to achieve. But let us focus on sharing meaning first. Now, this slide I love because there is a whole health system of a country, say Wales, and this may be Dr. Farr in front of it, putting everything onto the whiteboard. And then taking it one by one, every encounter, health services contact, aggregation, and digitizing it. And I believe if Dr. Farr were living today, he would do this digitalization and then putting it all together. So what we did is exactly what we assumed Dr. Farr would do. We have the international classifications. Those are the international classification of diseases. Then there is a very important classification about functioning and disability, what people cannot do when they are ill. And there is a third classification as health interventions, what people do when they receive care and so forth. So these, I call them Lego blocks of our classification world. And we use them in population health, clinical design, mostly for administration. When you call ICD-9-CM in the US, it is for reimbursement and billing. And of course, in WHO and member states, we use it for reporting purposes too. So this was the picture when I inherited the classifications unit, screaming and crying that I won't leave mental health. But then, well, there was the electronic health records coming to a theater next to WHO, and we watched the movies about e-health, delivering, long-term, pervasive information about womb to tomb. And we said, how can we make them work for classifications? So, of course, terminologies was something, and we started to work with SNOMED CT, but what was the key was the knowledge representations. And we tried to build that. So I'll tell you a bit of that story. That will give you the gist of what we are doing. And basically, if you conceive this well, this will give you a very good example about what we are going to do in the future as well. Because once we have a hammer, as you know it, everything to us looks like a nail. And our colleagues in CERN near Geneva says that once you have a collider, everything is a particle. So we apply the same principle. So then the story is about the ICD revision. We had the ICD-10. In 1990, it was adopted, and Americans have not still switched from 9 to 10, I warn you. And, well, I was asked to revise it by 2000, in 2 years' time. I said, no way, Jose. I mean, in 2 years, we cannot do it. It needs a lot of preparation. And the only thing that helped me was an IT trick. In 2000, there was the Y2K hype, Everybody was afraid that their computer systems will collapse big time. So I said, there is Y2K, we cannot do it. And I get a moratorium. So we went back to the drawing board. And the first two revision goals were the same all throughout the 20th century over the 10 revisions. But we put a third goal there. Ensure that ICD-11 will function in an electronic environment as a digital artifact and support electronic health records and information systems. So with that, there was implicit linkage to ontologies and terminologies like SNOMED, like gene ontology, and we would build certain logical operational rules like diagnostic criteria and linkage to archetypes and so forth. And that is my bias for ontologies. In '98, when I read a book. It was about Stanford's protege, and all my life changed. As you see in the cover of the New Yorker in this cartoon, ontology puts things into different classes so that computers can understand. It is not what you learned in your high school philosophy lessons, like Aristotle, Socrates did, nor what Sartre wrote in Being and Nothingness. It is a computer science which generates triplets about entities, attributes, and values, like RDF. And of course, then computers can speak to each other. Softwares can speak to machines. And if computers can do it, we said, well, humans can do it as well. Okay? So, in fact, that was nothing new. It is the knowledge representation from the famous triangle of Ogden and Richards. And we really tried to work with the concepts of disease rather than the terms. So it became a useful thing. So we built a content model for each disease to define a disease explicitly. Now ICD is no longer the simple list of FAR. It's not a tabular list any longer. It's a big ontology which has the following parameters. I won't bore you with this, but it is almost a relational database with 15,000 categories with value sets on each of these things. So we define a disease with their title, properties. We give each disease a textual definitions so that humans can understand, but that textual definition is parsed to symptoms, causality, temporality, severity, functioning, and specific conditions, so forth, so that the computers can make meaningful queries into that corpus of knowledge. So that corpus of knowledge we call the foundation component. It's huge, it's large, it's like a digital, library, if you will. I put all my songs onto my iPhone, but then, when I'm traveling, I make playlists for, road travel or for children or classical music or jazz. So the next thing that we do from this foundation component is a linearization. Basically, we recreate FARS list or anybody in primary care. We can create their list for a short list or, mortality list, morbidity list. For example, in the original ICD, malignant melanoma was listed as a neoplasm because FAR thought that cancers had a causality, so they should be all grouped together. And the dermatologist knocking on WHO's door every now and then, saying that, well, it's our disease, it's a skin disease. But in ICD, everything was listed only once, not to avoid double counting, because at the time there were no computers. So we can now put it in two different linearizations. It's like you play the same song in two different playlists. So what? As long as there is one representation and unique ID. So there is a foundation. We relate it to the SNOMED, other classifications and other terminologies, and we have multiple linearizations from that. So in this sense, you can guess the implications of this. Your primary care docs who are very well versed in read codes can talk ICD or SNOMED or, can talk to specialists and vice versa. You have almost like a Google digital maps in the classification, zooming in and zooming out in different ways. So this is the beauty of that digitalization. And we build it with some sort of an open and collaborative platform which is called ICAT. It is very close to Wikipedia, but it is not a blank page tool. It's a database entry tool, in a sense. It's structured by the content model. And you can write whatever you want. Even your mother-in-law who lent me your laser pointer could write something there, but it is subject to peer review, unlike Wikipedia, because we cannot let garbage go in there. So currently you can go to the ICD-11 website, and if you can't read the hyperlink there, just Google it, ICD-11 beta, you will, it's the first hit. And we have more than 30,000 people currently working on it as we speak. So it will be very nice to get your input into that, because it is basically opening it up, very transparent way, on an internet platform, all open. We have invited input from all stakeholders. There are already 17,000 definitions, and I would very much like to see whether they apply in the UK. And we are now entering into a phase for field trials to test it for feasibility, reliability, and utility. And we believe that with the work that we are doing, it's going to be electronic health record ready, but one of the field trials will show that. And it will be not only in English, but in other languages. So if there are other people not speaking, their English is not their mother tongue, you can also, we are crowdsourcing the translation in a structured way. So, as the Time magazine selects the person of the year, we say that it is you who are in control of the ICD. Welcome to your world, welcome to your public good, and build it with your comments, proposals, field trials, and with your review. That's what our beta phase is through. And if you do that, you can get brownie points in Facebook, LinkedIn, or social media of your choice. And by 2017, we are going to publish it after the World Health Assembly approval as a complex system. But as you can see, we are not doing it for once only. After that system in 2017, like Wikipedia, every minute, every second it will get updated, but we will have frozen versions every year to have statistical continuity. So there will be a perpetual digital editing in that system. So that is what we mean by digital readiness. In the audience, I see very many people who are coming from different sectors which we haven't connected before. You feel free to talk to me, write to me, and we would very much welcome if you can be part of it, because it's essential for electronic healthcare, care, decision support, safety and quality, better collaboration, better health information, and less administration. If you can achieve that, so good. And let me open a parenthesis there for the UK, because UK is one of the first countries who made an important change in creating the IHDSDO and adopting SNOMED. The former SNOMED enterprise, those of you who are old may remember, was belonging to the College of American Pathologists. And I was joking to them, how worse can you have as an image or a branding to become a college, American, and pathological? Therefore, they changed it into a network, global, overall healthcare, which is very good. And then at the beginning, we were fighting like these two mules, but at the end, we came together to harvest the benefits of the digital world in the terminology side and the classification side. So we really think that SNOMED and WHO classifications are synergistic, not antagonistic. And therefore, the biggest yield of this collaboration, which started in 2006, has become the common ontology. Now, what is common ontology is, there are some, let me just give you examples. There are some instances, ICD is stupid. It classifies phallotetralogy, for example, as a congenital disease. And of course, phallotetralogy is not only a congenital disease, but also a heart disease. So when you count the heart disease, those patients with phallotetralogy do not aggregate to heart disease. Conversely, in SNOMED, myocardial infarction is an infarct of the heart, but myocardium, and pathologically it doesn't aggregate to heart disease or ischemic heart disease, okay? So it was awful. So we said that, okay, let us have a shared semantic approach between the two. So at the end, looking at the WHO ICD's foundation layer, or SNOMED, disease, disorder, clinical findings hierarchy, it will be almost like Turing-like test. If you are using the common ontology, under the hood, inside your computer, you wouldn't notice whether we are using SNOMED or ICD. We should share the same information base, okay? So that is what we call common ontology. Every entity with its names, and it is polyhierarchy as to how it is classified as a parent-child relationship is becoming the same. So that is a good sharing of meaning as an example. So once we got there, this is our collider, this is our hammer, if you will. We would like to do it for ICF, for interventions, medical devices, everything else, so that the users can use systems interchangeably, if common ontology is achieved, of course. So far, we have done it for 7 chapters of 24 of ICD, and it is being tested, and it will be completed by 2017. But I also welcome any efforts to test it, to develop it further, to use it, and so on. Once we have it, then, for example, WHO defines what hypertension is, as what grade 1, grade 2, grade 3. Then you can run algorithms on that and classify it. I'm a psychiatrist. This is how you identify a depression, whether you have low mood, loss of interest, low energy, and 4 of the 9 symptoms of sleep, appetite, libido, and thinking. And SNOMED has given them codes. Those in the curly brackets are SNOMED codes. So if I know that, then I don't need to go into the field and make a depression survey. I can look into the electronic health records whether these symptoms exist, right? So that is what I call e-epidemiology neologism. And of course, SNOMED was good in many aspects, but they are not good in psychopathology. For example, thoughts of death doesn't have a code, but they promise that they will put it in, okay? So that is what common ontology does, binding it. So if we do that, it is not only for mental health. Beyond the lexical matches, beyond Google's, we can then start searching concepts about words. So it is not going to whether you spell diabetes or diarrhea. If you have the spelling of diarrhea in English, it is very, very difficult, for foreigners to spell it correct. So concepts are more important. And you can extract the concepts from health records. For example, you can see how many patients do have diabetes mellitus in Cardiff or Wales. And then you can automatically extract their hemoglobin 1AC scores, okay? And then compare Cardiff with Canada, okay? So, or, you can compare it with other UK denominations. So, as you know, you're getting electronic data everywhere. I'm citing Manchester data that Ian Buchan has provided us with the outputs. You have findings, events, interventions electronically captured if you have the electronic health records. In many instances in the world, they are used for reimbursement and resource management. I mean, Kaiser Permanente has it, and most of the use is for resource management and reimbursement. But you can use it for clinical information. So if a GP refers the patient to a nephrologist or an endocrinologist, they can share that information. Also, as I told you earlier, we can use it by making aggregations for epidemiology and surveillance. So we can do real-time public health. And that is what we would like to do. And I think if Far were with us, he would have liked to do that as well. One other thing, I don't know, I have been in touch with the UK with the map of medicine. We are also developing some primary care tools for the developing countries because WHO's basic function is providing health to all countries, and primary care is 80, if not 90% of the care provided all over the world. Suppose there is a patient coming with cough, and that is a SNOMED code. And then the tool immediately says, okay, the first thing that you can ask whether the patient has fever, because that is the, decision-making point. Then you ask the fever. If there is a fever, well, whether they have sputum. If they have the sputum, whether they have blood in their sputum. And then if so, the tool can say, take an X-ray, whether it's tuberculosis, and ask for a culture. And if there is tuberculosis, then give them dots, okay? So in a sense, such systems enable people to, use a common language, make an immediate record, and also cover their back legally that they have applied the, nice algorithms and, coverage. So that would be interesting to pursue. Eventually, as you can see, it is a slide that allow basically whether you're using a send clock, an analog clock, or a digital clock doesn't make a difference. Basically, we are all trying to say the same thing these three people are saying. And also don't forget what I said earlier. It's not only semantic interoperability, it's also the talking between them, the human interoperability. So we, the health providers, patients, and the IT sector has to speak to each other to really make the spiral of FAR go up. So our future steps that we are working is linking individual data to public health indicators, such as, child mortality, under 5 mortality, okay, or maternal mortality or obesity. Then also develop some sort of standards for public health indicators using the entities and their relations and the aggregation process. To do that, for those of you who are semantic web savvy, we also have established and have a certain API package which is on ICD codes, Uniform Resource Identifiers. So with a URI, it's like a URL. You can pinpoint an ICD concept without error and reuse it. And every time you use it, you have the tag of the URI. So we can, provide you with the perfect ICD code and metadata, and you can use it with different APIs. So that is a very new approach that we have been applying for the last 2 years. The more it is used, the more useful it will be. That's why I'm advertising. And it will allow us, after 5 to 10 years, to make some sort of impact analysis with semantic web, where on the world these ICD codes are used or not. And it may be useful for translations as well, because the same URI will refer to the same concept ID, independent of the language. Therefore, let me put the finishing touch. I say that e-health, digital health, mobile health, or X-health. I say in WHO, we might need to build a new building next to WHO and call it e-health, but that is not what I'm preaching, as you may have already understood. It should be a virtual building, and everything in health should be digital. So we should not create a separate digital health or e-health. Everything has to be digitized. That is the way things function. So when you are digitizing, please do remember the Tower of Babel and don't build yet another Tower of Babel. I come from Turkey, I said, and Herodotus was living in western part of Asia Minor, and he visited Tower of Babel, and he writes in his chronicles that, well, there was no tower, there was an immense ruin. It might have been great, it was a good idea, but it is useless. That's Herodotus' words over the history. I think those who don't know history are doomed to repeat it. So let us not build a Tower of Babel. So if you have any questions and answers, I've been within my time. Thank you very much for listening to me. Thanks.